All right, welcome everyone. In this masterclass, we are really going to dive deep into the incredibly complex and often intertwined worlds of autism spectrum disorder and ADHD. We're going to be working with some top-tier clinical material to unpack, everything from the absolute core characteristics all the way to the subtle nuances of diagnosis and management. So let's just jump right in. So, the expert guiding us through all of this is Dr. Jane McGrath. She's a consultant child psychiatrist with a service called ADMIR. And what that means is her role puts her right on the front lines, deep in the clinical practice of this field every single day. And as if that wasn't enough, on top of all that clinical expertise, Dr. McGrath is also the Associate Professor of Child Psychiatry at Trinity College Dublin. It's this exact combination of hands-on, in-the-trenches clinical work and really high-level academic research that makes the information we're about to go through so incredibly valuable. Now, that service she works with, ADMIR, is actually really significant, and here's why. It was the first specialist pediatric ADHD service set up by Ireland's Health Service Executive, or the HSE. I mean, this was a landmark step. It represents a huge move forward in creating dedicated national healthcare specifically for neurodevelopmental disorders. And over at Trinity College Dublin, her research is delving into some seriously cutting-edge areas. We're talking about things like neuroimaging, using powerful techniques like MRI scans to actually look at the brain's structure and function. Then there's mobile EEG, which is so cool. It tracks brainwave activity, but outside of a lab setting, so you can see how the brain is working in real-world situations. And of course, clinical studies, which is where the rubber meets the road, applying all these findings directly to make patient care better. Okay, so here's our game plan for today. First, we're going to do a deep dive into ADHD. Then, we'll shift gears to understanding autism spectrum disorder. After that, we'll get into the practical side of things, assessment and management. And we'll wrap it all up by tackling the really complex stuff, differential diagnoses and comorbidities. All right, let's get started with our first section, a deep dive into ADHD. We're going to explore its core aspects. Okay, let's kick things off with two absolutely foundational characteristics. First up, ADHD can be underdiagnosed, or it gets identified much later in life. This happens a lot, especially for folks who don't show that classic hyperactivity. We see this often in the inattentive presentation, and it's particularly common in girls and women, whose symptoms can be way more internalized. Now, the second point is huge. ADHD is highly heritable. And this is so important to understand. It's not primarily about parenting or the environment. No, there's a really strong genetic link, and that's why you see it run in families so often. All right, now let's move on to our second major topic. We're going to switch gears a bit and focus on understanding autism spectrum disorder. And the best place to start is with a really clear definition of the condition. So what is ASD exactly? Well, the formal definition tells us it's a broad range of conditions, and they affect two key areas, communication and behavior. And you typically start to see the signs really early, usually by the time a child is 2. Now, pay attention to that phrase, broad range, because that's the most important part here, and it leads us perfectly into our next question. Right, so the S in ASD stands for spectrum, but what does that really mean, in a clinical sense? Why do we call it a spectrum disorder? And here's the answer, and it's just stated perfectly. The reason we use the word spectrum is because there is just this incredibly wide variation, a huge range in both the type of symptoms people experience and the severity of those symptoms. It really means that no two people with autism are ever exactly alike. And this visual just illustrates that point so brilliantly. You can see on one end of the spectrum, you have what was historically called high-functioning autism, or Asperger's. This can actually be associated with extreme ability in certain areas. But then on the other end, you have what's known as classic autism, which might be associated with a severe learning disability. This really captures that vast range of abilities and challenges that the single word spectrum is trying to encompass. Okay, so how is this actually diagnosed in a clinical setting? Well, professionals use a guide called the DSM-5. That's the Diagnostic and Statistical Manual of Mental Disorders. And it lays out some really specific criteria. Let's look at the first one, Criterion A. This requires persistent deficits in social communication and social interaction across multiple contexts. And that means not just in one place, but everywhere, at home, at school, with friends. And just so you know, this is the first of several criteria that have to be met for a diagnosis, including another big one related to restricted or repetitive behaviors. And that brings us perfectly to our next section, clinical assessment and management. This is where we're going to shift our focus away from just diagnostic labels and start talking about the real-world human impact of these conditions. And listen, this is an absolutely crucial point. When a clinician is assessing a child, it is not just about ticking off a list of symptoms. The real core focus, the number one guiding principle, is understanding the impairment. What are the real, tangible difficulties that the child and their family are actually experiencing because of these symptoms? It's this human-centered approach that truly determines what kind of support and intervention is needed. Okay, for our final section, we're heading into some of the most complex clinical territory there is: differential diagnoses and comorbidities. So what does that mean? It's all about 1, distinguishing these conditions from other things that look similar, and 2, understanding what other conditions often exist right alongside them. You really have to have a comprehensive view to get this right. So let's break down what we're seeing in this table. Remember, a differential diagnosis is just the process of telling apart conditions that have similar symptoms. So a clinician has to consider other neurodevelopmental issues, like developmental coordination disorder, or DCD. But they also have to look at a whole range of mental and behavioral disorders. You can see things like ADHD itself, mood and anxiety disorders, oppositional defiant disorder, that's OD, and even obsessive-compulsive disorder, or OCD. Being able to distinguish between all of these, that is a truly critical clinical skill. Now, there's one symptom that is particularly concerning, and it's something clinicians are always on the lookout for: regression. That's when a child loses skills they already had. When that happens, it's a major red flag, and it tells the clinician they need to investigate 2 specific conditions right away. The first is Rett syndrome, which is a rare genetic disorder. The second is epileptic encephalopathy. This is a severe condition where frequent seizure activity in the brain actually starts to impair cognitive development. Okay, so we've talked about telling conditions apart. Now let's talk about comorbidities. Those are separate conditions that exist at the very same time. And this list shows some common medical and genetic problems that can co-occur. You see epilepsy on there again, along with various chromosome disorders, specific genetic conditions like Fragile X, and even some things you might not expect to see, right? Like muscular dystrophy or neurofibromatosis. And these co-occurring conditions aren't just, genetic or medical labels. They can be functional, meaning they affect daily life in a profound way. Just look at some of the most common ones here. Feeding problems, including really restricted diets. Issues with toileting, like urinary incontinence. Significant GI issues, like constipation. And then look at that last one. That statistic is crucial. Fecal incontinence, or encopresis, happens in a staggering 50% of cases. Half. So when you take all of this information together, the differential diagnoses, the medical comorbidities, the functional problems, it is all leading up to one single crucial clinical note. And here it is. This really synthesizes everything we've just covered. These associated problems, they are not rare exceptions. They are common. And because they're common, a clinician must actively assess for them to get a full, accurate, and compassionate picture of the person they're trying to help. It's really all about treating the whole person, not just a primary diagnosis. So we've really been on a journey here, right? We've gone from the core definitions of ADHD and ASD, we've explored the sheer vastness of the spectrum, and we've dived into the clinical realities of assessment. And all of that brings us to a final, crucial question to think about. When we see this incredible level of complexity and overlap, does a single diagnostic label ever truly capture the full picture of a person? Or is it maybe just a starting point? Thank you so much for joining me for this.